along and introduce our keynote speaker. And I'm really personally very excited by Professor Aarno Palotie from the Finnish National Genome Project, who's joining us today. He's the research director of the Human Genomics Program in Finland, also faculty member of the Center for Human Genome Research at Massachusetts General Hospital in Boston, associate member of the board of the Institute of MIT and Harvard, and has many more accolades besides. He's an illustrious track record in human disease genetics, and he'll talk about the Finnish Genome Project, FinnGen, which was highlighted by Professor John Greeley as a model for Ireland to look at the last IHRF event in November. So, Professor, you're very welcome.
Thank you so much for inviting me, and it's a true pleasure to be here. And of course, I'm delighted to talk about my own country, like any countryman should be, and tell you about FinnGen and how, from what soil that grew up, and what made it possible, and what have we learned so far. And I'm going to cover about half of my talk in the societal or governmental infrastructure that was built that made this thing possible. First of all, if you compare Finland to your country, we are about 5.4 million in the northeastern corner of Europe. We are very unevenly populated, so that most of the 1.5 million of the people live in the metropolitan area here in the south, and the parts of obviously of Lapland are very sparsely populated. So that gives you some insight and some vision to certain challenges we have to have in the country to organize things. The question then is that why are, for instance, I invited this morning to your event. So maybe that comes with an explanation that why Finland. So if we look at countries which have a universal healthcare system, have a unique identifier, have a biobank system, and then have also a population isolate structure. And so the number of countries becomes small. It means that it's not, I don't want to say that this is the only place, but especially I think the population isolate is one of the key facts that makes the Finnish situation relatively unique. And why are we doing all this? This is self-evident for you. The question is that from discovery to treatment and prevention is a very long path. And then the question is that could genetics do something on that? And what we can do from our perspective, it's standing on four basic pillars. I already alluded to the population isolate fact. The second one being in the Nordic countries, that due to our healthcare system, we have built national health registers in all Scandinavian countries in a way that is relatively unique, and I'm describing them a little more in some of the next slides. There's a long tradition also of epidemiological studies which have resulted in sample collections, and which then later became under the concept of biobanks. And then, of course, we have tried to learn how to analyze genome data. So the national registers, what it means is that, for instance, every time when you visit a hospital, wherever in the country you do that, it's the information and the diagnosis go into a central resource, which originally were built for administrative purposes to monitor the usage of healthcare. The same is with outpatient visits, outpatient procedures. Also, the primary care data is now collected since, I think, 2011. Cause of death data, and every time you purchase prescription drug, the drug information goes into a central database. And you connect these two, registers by using the individual identification number, if you want to call it social security number, and that is the key through all these registries. So these registries go, some of them go back all the way to the 50s, some are built in 60s, and then later even in the 90s. It means that the fact that they have been in digital format such a long time, it means that it provides quite an opportunity to follow the lifelong usage of healthcare services nationwide. And really every healthcare visit by every citizen through your entire life is registered. If you use the private side, which is clearly much smaller in Finland and mainly devoted to outpatient services, those registers have been included only now later. And at the time when Nokia went down and things didn't look so prosperous, so there were some think tanks in government that thinking that that healthcare system is something which have always been considered as an expense. So what about, could it be used for something else also, not only looking at it as an expense? So, excuse me, three ministries together, and as you can imagine, having three ministries together doing something is already a unique setting. Usually the borders between the ministries are relatively significant. And they started something which is called the health sector growth strategy. And what was, as a result of that, there was a national genome strategy developed. We are clearly behind the schedule on the milestones built in that strategy, but we do have now the Biobank Act, and we do have the Act of Secondary Usage of these health register data, meaning that not only for their primary administrative purpose, but that they can be used for research. And there is a bill for the National Genome Center. The Biobank Act is also, I use now the word unique pretty often. I know that it's a little bit of inflation, but there are a couple of aspects there. First of all, it's based on a very broad consent, that whoever wants to give their sample gives their sample and their data for healthcare related research. No more specific than that. You can get information to what your sample and data was used, but you can't. But if you consent to to a biobank consent, then you are not expected to restrict to which disease areas your sample can be used. You check a box if you like that there is a possibility that the biobank can recontact you, and there's a possibility to collect samples and data then also from the healthcare services. It covers the whole country. There are some 10 biobanks actually at the moment, and the Act states that collaboration with industry is okay. And how can this healthcare data, specifically the national register data, be accessed? The new thing is through the secondary act of register data is that there is a central authority called FinData that regulates and gives permission grants permission to use this healthcare data. It basically works under the Ministry of Health and Welfare, and the primary idea is that the data is then always analyzed in a secure environment, either the one that they have produced or something that the researcher builds them by themselves, and they collect the data from all these centers. Okay, this all sounds very, very nice and very clear and so forth. I have to say that the FinData personnel is very pro-science. They have a very good attitude and so forth. But the devil is in the details. And here we can see that already now that some of the details of how the act is written causes some challenges, and also the fact that maybe it wasn't quite taken into account how much work they will have, and it has become a little bit of a bottleneck for these permissions, even if there's a very good will to do. So this is something to consider if this model is adopted. Basically, they are also building in Finland now a shared environment for sensitive health and biodata analysis. On one hand, from items that can be very much open access, and some which are, on the other hand, are more sensitive, but provide systems that this can be accessed in this environment by the Center of Scientific Computing. And then again, when we come into the details, there is of course a little bit of maneuvering, because the Center for Scientific Computing works under Ministry of Education and Culture, whereas the health data is collected by the Ministry of Welfare, and the main funding source comes from Ministry of Employment and Economy. Just highlighting that if you are building some of these type of things, again, devil is in the details, how to execute them. But then work towards the FinnGen and towards why Finland really has some peculiar features, which comes from our population history. We were inhabited by small waves of people who moved in thousands of years ago in a few waves. And they mostly lived on the coastal region of the country. And then as we were part of Sweden, so in the 16th century, King Gustav Vasa demanded to populate also the eastern and northern parts of the country to protect for the eastern border. And then there was an expansion of the population, like in most Nordic countries. What it ended up with is this what we call a genetic isolate, meaning that specific variants, especially those ones which are low frequency in the population, became enhanced. And then again, some of the variants, like for instance, cystic fibrosis, is very, very much underrepresented in Finland. And it also provides an opportunity to use clearly cheaper methods for analyzing your genome, by doing it by chip methods and imputing against Finnish reference data. And this is obviously a lot cheaper of an approach than sequencing. So really it has these consequences for both medical genetics. It's easier to identify disease-associated genes, and from a diagnostic perspective, there is a unique spectrum of disease and genetic variants that should be tested. So FinnGen, it aims to have some 500,000 individuals, their health and genome data analyzed, roughly 10% of the population, combining some of the existing collections and prospective collections. All the samples are genome-wide genotyped and imputed against population-specific whole genome reference panel, and the most of the healthcare data comes from these national registers, and that builds the 500,000 individual data resource for association analysis. The FinnGen project is a public-private research project, and this is important to understand that this is a research project. This is and it's run chaired actually by University of Helsinki, but it has partners of all university hospitals, all universities that have a medical school, including also the Biobank cooperative, FinnBB, which combines coordinates all the biobanks in Finland. And the funding source comes from 12 pharmaceutical companies and the Innovation Fund Business Finland. And this is a true research project where we together, all partners, plan on the aims and the methods that we use. We specifically, if you think that we start from biobanks, the sampling the citizen, and then go all the way to population implementation as a dream. So the FinnGen puts itself in the early medical basic research collaboration with industry that we aim to stimulate more clinical research. So where are we currently? We are 3.5 years in the project. The project started in 2017 in August, and we now have collected 550,000 individuals from the goal of a 500,000 set. So we are pretty far along. And if you look at the data and compare it now, for instance, with UK Biobank. So what is characteristics for FinnGen is, first of all, our median age is relatively high. It's over 60 years, and we also have a proportion of deceased individuals, and we all have linked them to these healthcare registers. Oh, why does it now? Okay, now something happened. It froze. This was not expected. Okay, now, yeah, it was thinking a little bit. So in each, due to the high age, there are a mean of 340 health events per individual, including 186 drug purchases. So it's a lot of data. And this provides especially opportunities for longitudinal analysis. I'm not diving to the results today. The time doesn't allow. We can discuss it another time. But you can imagine that there is a lot that have been discovered and a lot that can be studied. Data protection is, of course, important for us. All samples are obviously pseudonymized, and the participation is voluntary, and the genome data is analyzed in a secure environment. And what is this secure environment? And I think this is something relatively unique what we have built. Now, to cope with GDPR and all the local regulations, we had to build an environment that fulfills the data security requirements. So it's an environment in Google Cloud that cannot be copied out. All partner scientists who have went through the tests and got to the permissions and all the bureaucracy needed can access the data, but cannot download it. So in other words, they can see the data, they can analyze it within the sandbox, but they cannot download it. And then we have what we call a green area, which contains aggregate level data, basically results, summary results, but no individual level data. And that is more easily accessible with less of steps involved. So what we now have developed is, and as you all know, that accessing this from outside EU is a regulatory challenge. So we now have over 150 users outside EU who can access this safe environment, and as said, fulfills the national laws, regulations, and GDPR, and so forth. So we think that it provides an example and potential solution for others. For instance, East London project is now adopting our sandbox. The same thing has been built for them. And then the summary statistics is then downloaded or can be accessed after a 12-month embargo. And currently more than 1,100 scientists around the world have downloaded the publicly available data. And as I said, there's a lot of findings. I'm not diving into them. For instance, there are 400 Finnish-specific gene associations as of now from the 320,000 participants that we have had chance to analyze. And just kind of remembering that yes, we do a lot of research. We try, and there's goodwill to build good legislation, but the reality is that we are not free of bureaucracy, and we do spend a lot of time trying to navigate in this world. Typically, the problem is that regulations and acts and laws are not in sync, so that one law says something and another law says something else, and how is the situation interpreted sometimes take a lot of lawyer time. And that means that it's not cheap. Building the environment that we have built has costed a few million. Our computing costs, just the bills we pay for the platform usage, is over $1 million a year. So this is good to remember that all this is costly, and it does consume money. And we think it's harvesting time. I thank you for listening.
Aarno, thank you so much. I have so many notes, but because I wanted to ask some questions, but I'm not going to, because the chat room has been going since you started talking, and there's a lot of questions. I kind of smirked a little bit when you showed that slide of the 3 ministries and the borders between them. I think a lot of us know once you start talking between health ministries and other ministries, it's very difficult. So it's an incredible achievement to have brought the ministries together, the pharmaceutical companies and the public. And as a result, we have so many practical questions coming through, because I think the familiarity with Finland being a genetic isolate as Ireland is, you know, there's so many commonalities between us. So the first question for you is, in your experience with FinnGen, what proportion of population-wide buy-in or consent would you have?
Yeah, so currently, as the biobank system is relatively new, it hasn't been in operation for too many years. So as said, we have now roughly 10% of the population are already in there. It seems that the enthusiasm is great. However, as the main recruitment place are tertiary care hospitals, it still could be higher. Now I can't quite remember by heart. Is it roughly 10% of patients that consent just without more activity?
Okay. And some of the investigators, I saw Liam was asked this one in particular about, can someone withdraw consent in the future? Yeah. And what impact does that have on ongoing studies? And has dynamic consent been considered?
So how it typically goes is that how we interpret the situation, if the data set has been already constructed and that has been used for analysis. So we don't take that person out from that data set, but we refresh every 6 months the data that we use for our analysis and take those out who have withdrawn. The percentage is very small. Okay,
so it's quite. But so if you have my data, I can withdraw it at any time.
Yes, you can.
Yeah, that's fine. So where are the samples coming from? Is there broad representation from different social classes, ethnicity, medical diagnosis? Because I know you said that there's a high level over 60s. So in terms of their backgrounds, would it be broad and diverse?
It's quite broad because this is a mix of things. There are old population cohorts involved, and then the current recruitment goes mostly from tertiary hospitals, meaning that anyone who is ill, and we haven't seen any unusual representation of the social background, though we don't have a lot of social data that we would have analyzed. But we also have the blood donors, which is a very healthy young population. So it's a mix.
Okay. And just on that, because there was a question from one of our patient advocates, before this began, how did you engage the public in the setting up of this multi-stakeholder research project?
Yeah, that is something where to be quite honest, I think we could have done even a better job, because our patient organizations are not that active, like for instance in UK and Ireland. And we tried to involve them, and they were involved, but they were not terribly active. So what we tried to do is public, TV, press, organizing public events and so forth, so that as many people as possible would be knowledgeable about this. How many at the end of the day is another story.
Okay. Who owns the data?
Yeah, the data depends a little bit on the data. The genotypes are owned by the Biobank.
Okay.
So that but that's contractual basis. And basically the Biobank Act says that any data produced with the samples should be returned to the biobanks, so that the biobank can then use it for other studies. So in that sense, they are at that point owners of it. But then there are, of course, results. And when you say that who owns the data, it depends.
Yeah, I know.
Data. The results is typically owned, obviously, by researchers.
Yeah. Okay, it's an important question for us in Ireland, and one that we labour over. So in terms of, one of the final questions here is, what's the commercial model with pharma companies? How do they get out of it, and how much time do they have exclusive access for? Like I saw at one point, they can see data, but they can't take data. Is that correct?
That's correct. So
yeah.
So this is really a research project where the idea is to build I shouldn't say infrastructure, but a resource that can be broadly used, because the pharmaceutical companies need more data, and this is a way to build data. So they have 12-month time, all partner researchers, including academics and the pharma, for an embargo. After 12 months, the results are released. The individual level data we cannot, because UK Biobank is unique in that setting that it can be distributed, but legally we can't just throw it kind of on a public repository, but have to collaborate with us.
And just on that, so in the context of, how do you manage feedback of results where there's incidental findings?
Deep breath.
Sorry, I promise this is the last question.
Yeah, and the question to which I have the worst answer. This is something that we are working very hard on. How should that be organized? And the Ministry of Health and Welfare would like to have a kind of a national policy on that one. On the other hand, we know that ministries are not very speedy. So indeed, we have ended up in situations where, for instance, the breast cancer groups are thinking that we cannot just sit and wait. We need to build projects in one way or the other that have an impact on the patient more quickly.
Okay. Okay, so I think we've learned a lot, and we're just up. Our time is up, Arno. So
Yeah.
thank you so much.
Thank you.
I'm absolutely certain we will all meet you again, and we will follow with interest what's happening in Finland, and learn from you. And I really appreciate your honest, advice this morning. You let us know what worked well, and where potentially even that engagement with the public. Maybe you could have done more of it, and we need to learn to do that here as well. So thank you so much.